it works. Okay. So, what I'd like to do is introduce our next speaker. Robin Poulier is really going to be the gel that brings together today from a clinical, functional perspective. So it really, her background is as a wonderful clinician with close to a decade's experience, and as really her practices focus more on really understanding the physiological differences between patients. So this sort of advanced, personalized, functional approach to nutritional therapy, and she's going to take you on a journey into that approach and within the context of a case discussion. So I think it'll just beautifully meld where we've been going and give us a bit of trajectory for where we're going to go next. So with that in mind, I'll hand it over to you. Okay. Thank you.
Thank you very much, Ben. Can everybody hear me, first of all? No. Okay, let me just play around with the mics a bit. How about now? Is that better? Is that microphone on? Yes. Okay. Somebody technical, can we turn the sound up? There's not a volume button that I can see, so that's the extent of my... Do you want me to use the lapel mic?
Yeah, it's attached to the lapel.
Okay.
Yeah. I think what we'll do is attach the lapel maybe.
Okay.
Yeah, if you want to pop it in your side pocket maybe. Should be good.
Okay.
Give me a moment to get back upstairs.
Okay.
Yeah, I'll sort it.
I got it. Is it
You
on?
want to put on there? Be all right there? Yeah.
Is it on?
Yes.
Will be when I get back upstairs. This is muted.
Oh.
Alright.
All right. Sorted.
Thank you. Okay, is that better? All right, well, welcome everybody to the afternoon session. I hope not too many of you have insulin resistance or reactive hypoglycemia and you'll be able to stay awake after lunch. As Ben said, I'm going to be walking you through one of the case studies from my clinic this afternoon. And the case study is really looking at fatigue, and in this case chronic fatigue syndrome, as a brain-based issue. And in the course of working through this case with this patient, how we've had to tie in the gut-brain axis and the gut in order to treat the brain and the mitochondria. And also, as Ben said, actually what we're really looking at is tying together in clinic, how do you actually think about and how do you process all of the fantastic information that Ben presented this morning and a lot of the things that he's going to be talking about as well this afternoon. So without further ado, I would like to introduce you to Zoe. So when she came into my clinic, which was October last year, Zoe was 16. And at the age of 13, Zoe actually fell in gym class at school playing hockey, and she hit her forehead on the hip bone of another student. She didn't pass out, and because she didn't pass out, she wasn't sent to the nurse immediately and continued on with the rest of the gym lesson. And then the class after gym was actually music. And Zoe has been playing the flute since she was a very young girl. She plays the flute every day. And when she got into her music lesson, she discovered that she just couldn't make the flute sound right. She couldn't coordinate what she normally does without even having to think about it. Her music teacher understood immediately that something was wrong and sent her to the school nurse. The school nurse was not particularly concerned and basically just gave her an ice pack and had her lie down for the afternoon. However, when Zoe's mum picked her up from school at the end of that day, she immediately saw that there was something wrong with her daughter. She was very pale, she was clammy, she was very, very quiet. And was complaining of a headache. And actually, Zoe has never been well since that moment. After a few days, when her headache was persisting and she wasn't really recovering, this family started the round of visiting the GP and the emergency room and the doctors to try to get answers as to why this headache wasn't going away, why she was continuing to be fatigued, why she wasn't getting better. They had a very extensive panel of complex medical tests over the next 6 months, including MRIs, X-rays, blood work, and everything came back quote unquote normal. And as the time progressed, Zoe continued to actually get worse. So the headache persisted. She started to develop pretty severe fatigue. She couldn't wake up in the morning. She was overwhelmingly sleepy the entire day. She couldn't concentrate. She was very easily distressed, very tearful. And she started to get neuromuscular pain. She was eventually diagnosed with post-concussion syndrome and then diagnosed with chronic fatigue syndrome. And then she was referred to the chronic fatigue unit in Bath to have energy management work done. So the energy management strategy that was implemented by the chronic fatigue unit in Bath was actually relatively successful with Zoe. Over the course of 2 years, they basically had to track every single activity that Zoe did in the morning, from getting out of bed, brushing her teeth, having a shower, literally everything she did, they had to track it, and they had to start to recognise and start to gauge things that were energy drains and things that used a lot of energy using a colour coding system. So green is something that didn't fatigue her particularly, red was something that caused a lot of fatigue, in order to understand what activities she was doing. And this is, again, it's a very useful strategy. So they started to understand that things like watching the television was a big red zone for Zoe. And once they had mapped all of that out, which is quite time consuming, then they just worked on what the baseline level of exertion was for her during the day, and then started working on increasing that by slow increments over a period of time. So after 2 years of working with this program, she was back at school every day, able to be a little bit physically active, and generally kind of coping with her life in a better way. However, both Zoe and her mum really understood that this regimen wasn't really fixing the problem, but it was making it possible for Zoe to function. And so they were satisfied with that, and they didn't really have any other solutions. They weren't being given any other options. So everything seemed to be okay, and she was coping, and sort of life was continuing on, until one morning in January of last year. Zoe woke up. She was going around her usual morning routine, and then seemingly out of nowhere, she relatively dramatically was sick with what appeared to be a minor stomach bug. It took her a couple of days of being at home, but this relatively minor stomach bug triggered a complete relapse of symptoms of her fatigue, headaches, and the addition of a crippling abdominal sort of diaphragmatic pain and near constant nausea. So that was January. By the time they saw me in October, none of the energy management strategies worked anymore. They'd been back to the doctor multiple times, who again hadn't been able to provide very much in the way of solutions or answers as to why this was happening. And as is very often the case, and I have learned to take this as a compliment, by the time they came to see me, they were pretty desperate, which is how I was even on the table in the first place. They were looking for alternative therapies and alternate avenues to take, because they had, over 3 years, not really had a lot of satisfaction from the conventional medical approaches. So Zoe's presenting symptoms when she, when I saw her for the first time, overwhelming fatigue. She was essentially sofa bound, she was housebound, she wasn't going to school. She was just exhausted all the time from minor exertion. She was very easily overwhelmed by things that we don't even think about, like having a shower or sitting down for a meal with her family. She was in pretty constant pain, which really centered around her GI tract. And when she had these spikes of pain, her pain level all the time was, she said, about a 5 or a 6 out of 10. And then once or twice a day, lasting about an hour, the pain would actually spike up to what she described as an 11 or a 12 out of 10. And it was accompanied by a strange hot flush and cold sweat that didn't actually accompany any change in her body temperature with a thermometer. During that hour period twice a day, she was unable to walk. If she had to go anywhere, she would be doubled over. She needed assistance moving, or she would have to hold onto the furniture or door frames in order to perambulate. Her sleep was understandably very poor. Mostly due to the pain, she was unable to fall asleep. She was waking often during the night, and she certainly wasn't finding sleep to be restful. And she had a lot of GI symptoms by this stage. She was very, very constipated. She was moving her bowels once or twice a week on a good week. Often it was less than that. One of her biggest issues was this extreme nausea. The nausea was much worse in the morning. Sometimes she would throw up. But the nausea was pretty much there all day. And I promise you, having just gone through first trimester morning sickness, I have a lot of empathy now for all-day nausea. Her abdomen was soft, but she found palpation unbearable. She couldn't stand to be touched in the abdomen, and she had an additional diagnosis of IBS. She also had a constellation of other symptoms, including recurrent oral thrush, urinary tract and kidney infections. She was losing a lot of weight. She was actually now very underweight. She'd lost almost 10 kilos in the course of 1 year. And just had this really complex presenting clinical picture where it really did seem like everything that could go wrong with this girl was in the process of going wrong or had gone pretty severely wrong. She was taking all of these medications every day, 2 of everything for everything. So 2 inhalers for asthma, although she'd been taking those for quite a long time since she was a child. She was taking paracetamol and Nurofen for the pain, which were taking the edge off but not really changing anything. She was taking 2 antiemetic medications for the nausea. She was taking amitriptyline and buprenorphine, which was again to try to help manage the pain, which were not particularly helpful, and the buprenorphine particularly made her feel more nauseous and really contributed to the constipation. And she was taking 2 laxatives to attempt to help her move her bowels. So even with that amount of laxative, she still wasn't really managing to go to the bathroom more than once or twice a week on a good week. She had also, over the course of the 12 months, tried a long list of other medications, none of which were particularly effective by medical standards and were therefore discontinued. So I took a comprehensive history, and there wasn't, up until the head injury, there wasn't really a lot in the way of major issues that jumped off the page, but there was a lot of things that in the context of her history you can actually see have really set her up for when something went wrong. She had a lot of predisposing antecedents that allowed her to really crash once she had a big enough trigger. So those include multiple chest infections when she was very young, including many, many rounds of antibiotics. And she had had asthma since she was 5 or 6 and had been using inhalers every day since she was 10. So you can already start to see that even though she didn't have a C-section and her birth, and she was breastfed, so she was set up relatively well, that her GI tract and her immune system and her gut flora were probably not very healthy. from a very young age, and that helped to set the stage for what came next for her. Her diet was pretty standard. All in all, I've definitely seen a lot worse, but it is very much the standard British diet with a lot of processed foods. Mum did prepare food. This wasn't a takeaway family. Takeaway for them was a special occasion thing. But supper was usually cooked from scratch, but lunch and breakfast were very much, breads and convenience foods and lots of wheat and pro-inflammatory grain-based diet. She was drinking water and fruit teas, not a lot of soda, but still nonetheless, again, pro-inflammatory diet, which really helped to bring her into a pro-inflammatory state. So one of the things that I often do in a first appointment, if I'm ordering labs, I'll put a basic nutritional intervention into place and I'll recommend some simple supplements not to be started until after the labs, all of the tests have been done. And in that period with this family, I got this email from Zoe's mum. So while they were in the process of taking the test, but before they'd started on the diet and before they'd started taking any of the supplements, where she really expressed a significant amount of fear around her daughter's health. And I think that this really illustrates the sort of hopelessness and anxiety that this family was feeling, having watched their daughter over the course of 3 years pretty much lose her life and her ability to function. She says she's becoming increasingly concerned, she's becoming frightened where this will lead if they can't get control of it. And that while Zoe is making a very big effort to try, her goals for the day at 16 years old, she has 2 goals for the day. One is have a shower. The second one is play the flute, which is her favourite thing, for 10 minutes. Both are massive struggles and leave her exhausted, and she's not managing to do both of those every day. So that's where she's at. This is a pretty critical situation for a young girl. So based on that cacophony of symptoms, what do we have here? So we obviously have some pretty significant GI dysfunction. Whenever there's fatigue, we know that there has to be mitochondrial dysfunction of some kind. And due to the brain injury, it seemed obvious to me that we have neurological inflammation. So all of this was essentially triggered by this head injury. And when we layer that onto the predisposing factors in Zoe's history, then we end up with this very critically ill young lady. So in a complex case like this, where you've got that massive constellation of symptoms, how do you know where to start treating? You can't treat everything at the same time, which was something that took me a couple of years of clinical practice to stop trying to do. It is not a good idea to try to do that, even though it's very tempting. You've got mitochondrial problems, I've got to give you something for the fatigue. You've got sleep problems, I need to give you something for the sleep. You've got pain, I need to give you something for the pain. This is not an effective clinical strategy, and it's pretty overwhelming for the patient, in my experience, when you try to do that to them. So how do you decide what to work on first and in which order to do things? How do you decide what's the most important thing and where to begin your intervention? So stepping back, once I'd mapped that onto the timeline, once I'd mapped it onto the matrix, I took a step back from that and I wanted to have a think about what were the biochemical and physiological things that were jumping out at me from this case. So my initial reaction or my initial workup of the case were, from the brain symptoms that she has and from the fact that this all started, it was all triggered by a head injury, we've obviously got neuronal and microglial dysfunction in the brain. We've obviously, and the thing that actually jumped out at me more than anything else was vagus nerve. That there was a very big interplay with the gut-brain axis happening here, and that the vagus nerve was obviously central to that. And it seemed very, very obvious and very clear to me that in that initial insult, in that initial injury, that that inflammatory process had had a big negative impact on the vagus nerve, and that it took a couple of years for it to come to the fore, but that had allowed this issue of fermentation and stagnation to happen in the gut, which had eventually led to her having the kind of GI dysfunction that she was presenting to me with now. And she also appeared to have multifocal dysbiosis, in that she had dysbiotic flora in multiple regions of her body, her mouth, her urinary tract, as well as her GI tract. So the biggest issue with Zoe's triage was actually that each of the primary issues that she had are perpetuating the other two issues. So again, understanding where to begin unravelling this case was tricky. I had to think about it because each thing, I could have started with this one because this one affects those two, and that applied to each of the things that I was having to think about for Zoe specifically. So in order to illustrate where and when I started to think about how to intervene, I'm going to walk you through some of the science and some of the ways that all of those three different systems are impacting on each other. And we're going to start with the brain and mitochondria. So I actually started my career working with skin, and I loved working with skin very, very much, because while the eyes are the window to the soul, your skin is very much your window to your internal health. It's the organ you can see. It's the only organ that you have visual access to on a daily basis, and it's a fantastic illustration of what's going on internally as a result of that. But your window into your mitochondrial health is very much brain health. So again, it actually, by understanding the brain and by assessing brain function, we are able to to understand what's happening with the mitochondria a lot of the time. And we do that not necessarily by doing extensive and expensive laboratory testing, but just by observing the patient, making observations about their behaviour, and asking questions about their fatigue specifically. So we're looking at brain endurance, looking at facial tone, we're looking at fatigability. In her first appointment, which was a virtual appointment because they don't live in London where I practice, and Zoe was functionally unable to travel in to come and see me. So the first appointment with her was over Skype, and she lasted 12 minutes. At the end of that 12 minutes, she went white as a sheet. One half of her face started to sag, and she looked like she was about to pass out. And she went and lay down, and I finished the rest of the consultation with her mother by proxy. So her fatigability for sitting and talking was 12 minutes, at which time she'd used up her entire supply of ATP and had to go, and that was probably her for the rest of the day. So that is a very big indication that cognitive effort had pretty much wiped out her mitochondrial reserve for that day, and that is obviously a very big insight that this is brain-based fatigue. So when someone comes into your office and they're talking about fatigue, ask them to tell you about it. What is it that tires them? Is it they can go to the gym and do their normal workout, but it takes them a week to recover from the normal workout? Is it they get tired from reading, or they get tired from speaking? Are they tired when they wake up in the morning? The kind of fatigue that somebody is telling you about will give you a big insight into the locality and whether or not the fatigue is brain-based. So it seems very clear in this case that it was very much brain-based fatigue. So when you have a problem, an inflammatory problem or a mitochondrial problem that originates in the brain, that has a very big impact on fatigue in the body, because you end up with extremely poor endurance for ordinary tasks like having a shower. So as the brain fatigues, the brain's output to the rest of the body is completely compromised. All of the signals, because your brain is driving all of the different functions in your body. Your brain is driving your gut, your brain is driving your muscles. And when your brain is fatigued, the output is reduced, and so the body fatigues as well. So anything that stimulates the brain and that's stimulating neuronal activity in the brain, such as light or noise or watching television, overwhelms degenerated and exhausted neurons. And this is essentially what causes fatigue or chronic fatigue when it relates to the brain. So here is a more comprehensive list of things that might trigger your, things that will give you a clue in clinic that what you're looking at is actually a mitochondrial issue. So from this list specifically, Zoe has a list, she has several symptoms that pop up on here, but a lot of her symptoms really, you see them underneath the GI, the GI panel. She has significant dysmotility, she's very constipated, she's been diagnosed with irritable bowel syndrome, she is vomiting. But some of the hallmarks of mitochondrial disease, again, really Zoe's case jumps out at this, is an atypical presentation of a common illness where you've got more than one organ system involved, where there are recurrent setbacks or flare-ups of a chronic issue that occur with something like infection or stress or something like having a local or a general anaesthetic. And mitochondrial illnesses are also very unpredictable in time, in severity, and in the constellation of the presentations. Now, here we have a fantastic graph that demonstrates the different energy requirements of different organs and organ systems in the body. And you can see from this that the brain actually uses 22% of the overall resting energy expenditure of the body, even though the brain only makes up 2% of the total body weight. So if you compare that to the other things that use a lot of energy expenditure in the body, we've got the liver, which uses 21%, and we've got muscles, which actually use up also 22%. So these are the organs and the systems that use up the majority of energy in the body. But compared to the muscles, for example, both of them using 22%, muscles make up 40% of the body weight, whereas the brain only makes up 2%. The gut so the immune system and the gut also use up about 16%. So you can see that for Zoe specifically, her brain and her gut, between the two of them, are two systems that she has significant compromise in, that she doesn't have the ability to drive with the energy, and essentially because they're so compromised, are wiping out her energy. So another interesting thing is that if you have a look at the density of the mitochondria per cell, so your heart has 42 mitochondria per cell in the heart. Your brain, on the other hand, which uses, remember that one of the highest percentages of energy, of ATP in the body, actually only has 5 mitochondria per cell. So despite the fact that there are significantly less mitochondria, they are in fact working really, really hard, really overtime in the brain. And here we just have another good visual of where energy is used in the body. So again, brain uses 22% of the ATP in the body. So when we're talking about how to treat the mitochondria, how do you go about thinking about fatigue? What do you do about it? What kind of things are you going to put into your treatment protocol in clinic? So there are two sort of ways of thinking about treating mitochondria. So the first one is known as a single nutrient model, although it's unusual that you would actually just give a single nutrient. It's normally a combination of the nutrients that we think about. And the second is really looking at systems biology. where we're looking at environmental factors and things within the body that are actually affecting the ability of the mitochondria to work, even if they have all of the nutrients that they require. So we need to look at food and diet and nutrients for the nutrient model. And we also need to think about clinical mechanisms that affect oxygen and glucose delivery, and inflammatory mechanisms, anything that's going to impact the ability of the mitochondria to work. So first, I'm going to run very quickly through some of the nutrients that you might think about when you're supporting mitochondria, although Ben went through them in more detail than I'm going to go through this morning. And we'll probably be talking about some of them again in more detail this afternoon. And you're probably very familiar with this set of nutrients because we all actually have a relatively good understanding that the mitochondria needs acetyl L-carnitine, alpha-lipoic acid, magnesium, B vitamins, antioxidants, D-ribose. These are not things that are unfamiliar to us when we're trying to work with helping the mitochondria to produce energy. Ben also touched this morning on phospholipids, and he talked about phosphatidylserine being very good for the brain and very good for the membranes. So membrane phospholipids are, clinically can be very, very effective because they help to repair the mitochondrial membrane and they help to support, transport across the membrane there. And, some of these products, when used therapeutically, have been shown to increase mitochondrial activity by up to 26%, which is very, very significant. And then the second branch of treatment that we need to consider is environmental and clinical mechanisms. So we're thinking now about environmental toxins, we're thinking about, like I said before, oxygen delivery, glucose and fat delivery to the mitochondria to be used for energy, and we're looking at inflammatory and reactive oxygen species mechanisms, and all of the things that you need to think about in terms of this patient's body that are actually affecting the ability of the mitochondria to do their job. So here is the triage, the differential diagnosis when you are working up a fatigued patient. If you have a patient that comes into your clinic, like Zoe, who has significant digestive issues and is not eating a particularly nutrient-dense diet, then it is extremely likely that they do have some of the nutrient deficiencies and that single nutrient model is going to be clinically quite effective. There was no way when she came into my clinic that Zoe had great levels of magnesium, great levels of zinc, great levels of CoQ10. She wasn't eating organ meats, she wasn't drinking bone broth, and therefore that nutrient model is a very good place to start. But a lot of the patients, when they present in my clinic, they've seen already, 5 other people, they've seen other nutritionists, they've seen physicians. Their diet is fantastic, they're eating autoimmune paleo, or they are already having bone broth, they've taken every supplement that you can think of. It's very unlikely in those cases that their fatigue and their mitochondrial dysfunction is actually being driven by requiring more B vitamins or requiring more magnesium. And in those cases, I'm not going to be the person that says, oh, well, you're obviously not taking the right supplements, stop taking those, and here, let me prescribe you this entire other set. So what we start looking at then is, physiological and clinical mechanisms that are impacting the ability of the mitochondria to work. So the basic needs of the mitochondria outside of nutrients are substrate, so glucose or fat, and oxygen. And so what are the things physically that we look at that impair the ability of the mitochondria to use those things? So anemia is an obvious one, or anything that's actually affecting circulation and the delivery of blood around the body. We're also looking at energy metabolism. Does your patient have hypoglycemia? Are they insulin resistant? What is it that's actually presenting? What is it that's happening in their body that is preventing basic glucose, basic sugar and basic fat from getting to the mitochondria in the first place, because without those things we don't have fuel and we can't make ATP. Anything that's promoting inflammation or oxidative stress, such as infections, such as inflammatory reactions to foods, dysbiosis in the guts, liver dysfunction. You know, is there a phase 1 or a phase 2 issue in the liver? Because all of those things are going to create oxidative stress and inflammatory, pro-inflammatory cytokines. And when that happens, you end up with uncoupling of the mitochondria, which means the mitochondria is not able to perform oxidative phosphorylation, which you need to make ATP. Is there a thyroid issue? Is there something going on with the reproductive hormones? Is there a structural issue? Is there something musculoskeletal that is increasing the energy demands and therefore reducing the quantity of ATP that's available for other things? So in Zoe's case, more specifically, she very obviously has issues around infection. She has an inflammatory diet. She's probably having some dietary sensitivities. She's definitely got intestinal permeability. I don't feel like she's an autoimmune patient at this early stage, and I'm not really considering so much the environmental pollutants, but all of that first line inflammation and oxidative stress that she's got going on is going to be having an impact on her mitochondria and preventing her from producing adequate ATP to fire her brain. She's definitely got impaired GI function. She's got, without having done the tests yet, I would say there's a very strong chance she has dysbiosis. She's definitely got poor vagal tone. And it's very unlikely that she's making digestive enzymes. So she's not absorbing nutrients that are required for the mitochondria, on top of creating all of that oxidative stress and inflammatory chaos. So no major obvious liver dysfunction in this particular patient, except that she's taking 10 medications every single day and has taken multiple others over the course of the 3 years from the time of her injury to the time that I saw her. And again, all of that medication not just creates a significant amount of oxidative stress, which has a negative impact on the mitochondria, but the medications themselves have a direct negative impact on mitochondrial function. And I'm going to come back to, well, actually it's on the next slide. So when we look at this list, okay, this list is actually talking about liver mitochondria specifically, but it certainly applies to mitochondria in general. So if we have a look at the medications that Zoe is specifically taking on a daily basis, she's taking these medications because she's attempting to treat or to suppress the symptoms that she has from her mitochondrial dysfunction, and they are perpetuating and making worse her mitochondrial function. So paracetamol has the ability to create something called mitochondrial permeability transition pore, which is a protein pore that opens up after a trauma of some kind. So Zoe probably had some of this going on because of the traumatic brain injury. It is actually something that occurs as a result of traumatic brain injury. And on top of that, she's taking paracetamol 4 times a day. And when you have this pore, it's a protein pore that opens up in the mitochondrial membrane that creates cell swelling and actually creates mitochondrial death. Some of the medications are preventing her from using fats. You know, they actually block fatty acid oxidation. And again, as Ben mentioned this morning, fats, if you can use fats or if you can use ketones to make energy, it's a much cleaner burning source of energy. It creates less oxidative stress as a result of making ATP. So it would be a very good and very useful therapy to bear in mind for Zoe, except that because of the medication she's taking, she's very unlikely to be able to process fats for energy. So some of the medications that she's taking have the impact of uncoupling Again, coming back to that uncoupling the mitochondrial inner membrane. So unable to actually perform oxidative phosphorylation to make energy. Oops. And they're also inhibiting just generally the respiratory chain. And these, apart from the Butrans patch, which is, not that commonly prescribed, Nurofen and paracetamol, these are things that people take on a regular basis. They don't think twice about taking these medications, and they take them sometimes, in this case they were taking them as medically directed, but people take them like Smarties. They don't think about if they have pain, taking sometimes twice the dose that is indicated on the packet or has been recommended by the physician. And remember that pain, neuromuscular pain, neurological pain, is definitely one of the features of mitochondrial dysfunction. So again, it's this, is the cure worse than the original insult? So again, one of my initial questions around Zoe's case was, or one of my initial assessments of Zoe's case, that we had this very distinct, microglial and neuronal dysfunction. So I want to just take a little bit of time to talk about the cells that we find in the brain specifically. So we'll start with neurons. So neurons are the cells in the brain that use electrical charges that they transmit information. They discharge chemical messengers that we know as neurotransmitters. And the basic requirement of a neuron to work is oxygen, glucose, and stimulation. Very similar to the mitochondria, which also requires oxygen, glucose or fat, and stimulation. And then we have this intriguing little neurological cell, or brain cell rather, called the microglia. So the microglia are basically, they're the army of the brain, they're the immune soldiers of the brain, and they are the most prevalent type of cell in the brain. There are 10 glial cells, so 10 immune cells for every neuron, and more than 50% of the brain weight is made up of immune cells. So think about that, 50% of brain weight is made up of the immune system. And have a think about what that means in terms of the impact that inflammation has on the brain and on neurological function. So when they're activated or when they're overactivated, they cause a significant amount of neuroinflammation. And the other interesting thing about the microglia, when you compare it to the immune system in the rest of the body, is that there is no off switch. So in your body's immune system, you have something called T suppressor cells. If you didn't have T suppressor cells, when you got a splinter in your finger, you'd probably have to take a couple of weeks off work and then end up having your finger amputated, because there wouldn't be anything to tell your immune system to stop that inflammatory process from happening. But you don't have suppressor cells in the microglia in the brain. And so when you initiate inflammation, not only is there nothing to tell it to stop, but these microglial cells actually actively recruit each other to continue on this inflammatory process. So here's a diagnosis that Zoe hadn't officially been given. Post-traumatic inflammatory encephalomalacia. But this is also known as traumatic brain injury, and it's a really, really well-known issue for sports people. So Zoe's not a professional hockey player. Nonetheless, she did end up with a brain-based injury from playing hockey. And the consequence of having a head injury when playing a sport, or having a head injury in general, is this inflammatory cascade activation of the microglia that leads to ongoing neurological trauma that gets significantly bigger as time goes on, and over a period of time then leads to neurodegeneration and potentially neurological disease. So in Zoe's case, her injury wasn't severe enough to be visible as a lesion on the MRIs that I know of. I haven't actually seen the MRI myself, and I don't specifically know what the physicians were looking at. But it was certainly enough to create this massive inflammatory cascade that was immediately obvious. It was very immediately obvious to Zoe's mother, and that continued over a period of time until it tipped her entire body into crisis. So these are some of the mechanisms that increase the risk of overactivation of the brain microglia. So in Zoe's case, again, there was definitely head trauma, possibly blood-brain barrier compromise, poor oxygenation. Now, if we think about that, Zoe has had asthma since she was a child and has been using inhalers on a daily basis to manage her asthma. So oxygenation of her tissues generally was probably pretty poor and has been made significantly worse by her now sedentary lifestyle, where she has less than 10 minutes of activity per day. She probably has low brain antioxidant status because she's not absorbing antioxidants particularly, and also her diet is not really antioxidant rich. She has an inflammatory bowel condition, not a disease, but certainly inflammation coming off the brain. And I am going to be talking a little bit more about the auto-intoxication that Ben introduced this morning and how that was really relevant for Zoe. So again, when you see these things in clinic, you might not necessarily be thinking about brain inflammation as it relates to environmental toxins or as it relates to gluten consumption. Or as it relates to diabetes. But it definitely is something that you need to start to consider when you're thinking fatigue. Has there been something in this person's history, even if it was 5 years, 10 years, 15 years, 20 years ago, that has initiated that inflammatory cascade that is now presenting in your clinic as fatigue, or as depression, or as a gut problem, or as a serious diagnosis like Alzheimer's disease or anxiety or schizophrenia. So in a healthy brain, there is a healthy amount of communication between the two different kinds of cells. They interact with each other directly, and they also have these soluble mediators and neurotransmitters that allow communication between the two of them. So two of those neurotransmitters specifically are acetylcholine and noradrenaline. And I'm going to talk very briefly about acetylcholine specifically because it's very relevant to Zoe. So because we don't have these T suppressor cells, one of the mechanisms through which the brain does regulate the inflammatory process is actually possibly through acetylcholine coming from the neurons. So the acetylcholine is actually produced by the neuronal cell itself, but then the microglia have a receptor site specifically for acetylcholine. And the research really does lead us to believe that the release of acetylcholine can help to control inflammation and neurological inflammation specifically. I'm not going to elaborate too much further at this point, but I really want you to remember acetylcholine because I'm going to come back to it a little bit further in the presentation. So what can you do in clinic? What can you do? What can you think about in addressing neurological inflammation? So remember that Zoe has been taking a lot of anti-inflammatory medications that have not, for her, been particularly effective at reducing the neurological inflammation specifically. But there's a lot of research around chemical compounds found in foods and phytochemicals that show that they are extremely effective specifically for dampening down neurological inflammation. So 4 of the ones that you've definitely heard of and probably have easy access to include, again, curcumin, which comes from turmeric, resveratrol, from black and red grapes, catechins from green tea, and rutin, which comes from citrus fruits. And very specifically, for the brain, these provide antioxidant protection and reduce oxidative stress. They reduce microglial activation, which is very critical for someone who has an overactivated inflammatory cascade. They inhibit endotoxin-induced brain-specific inflammatory pro-inflammatory cytokines. So again, coming back to that gut-brain connection where we've got this auto-intoxication where the bacteria and the microbes that are released off the gut are actually having a direct negative inflammatory impact on the brain. These plant compounds are actually able to inhibit that process, which is really important. They help to quench damage that's being done to the fats in the brain specifically. They increase DNA repair and they're neuroprotective. So there is a lot that can be done. So coming back to Zoe, we're still at appointment 1. So I ordered labs for Zoe. And one of the first things that I did was I wanted to really look more closely at her gut. So I've ordered lactulose breath test, a comprehensive stool analysis, organic and amino acids, and a hydrogen sulfide urine test. Now, it is really unusual that I order all 4 GI tests for a single patient. When I've got a patient presenting in clinic with a GI problem, I usually just choose one. And choose the one that I think is going to have the biggest impact over guiding my intervention, guiding my protocol. In Zoe's case, I did order all 4 because I wanted to really, she was in so much distress and her GI pain and symptoms were so significant that I wanted to understand multiple things. I wanted to see as much information as I could about which specific microbes she had in her gut. And I wanted to know also about the entire length of her gut. Right, stool analysis, we're really just looking at the colon. Organic acids and lactulose breath test help us to understand what's going on in the small intestine as well, which I thought was pretty relevant for Zoe. And the lactulose breath test and the hydrogen sulfide breath test help me to understand what what problematic compounds are actually being thrown off by the gut that are going to be having an impact systemically. After those tests were done, also organic and amino acids provides mitochondrial information. So it's allowing me to have a look at her energy production specifically, as well as lots of other information about specific nutrients that she might be low in. Neurotransmitter information, there's a lot of information in those tests. Once she'd completed those tests, I put her on a low FODMAP diet and we started to do some therapies around supporting her vagus nerve. So I had her do some gagging and gargling exercises and I asked her to sing loudly, which I have to tell you she didn't do because it was weird for her to start singing loudly around the house. She's 16, I got it. It was enough that I asked her to gag, several times a day on purpose. This was when, appointment number 1 was the first of many, many times that Zoe and her mother looked at me with expression of horror, trepidation, let's say, like, I can't quite believe we're even having this conversation. It was the first of many times that they looked at me like that over the course of this year. And I explained why I was asking her to gag and gargle and we sort of moved on. So her supplements, before any of the test results came back, I did nonetheless put her on a relatively simple supplement intervention. And you can see from the supplements that, really I'm focusing on reducing inflammation more than anything else. I put her on a general anti-inflammatory. I put her on a specific neurological anti-inflammatory. I put her on fish oil. Now this is an extremely high dose of fish oil. I do not normally use fish oil at that level, but again, because of the traumatic brain injury and because of the neurological repair that I was attempting to initiate, I put her on this dose for 1 month only. And I got her to check it out with her GP to make sure that there was no contraindications before she started taking that dose. I put her on some magnesium citrate powder to get her bowels moving. Magnesium is also very useful for energy. So it has that added benefit, but predominantly I just needed her to be moving her bowels as often as possible. And I put her on some NAC because she was taking 10 medications every day. And the initial findings of her labs were, she had multiple strains of bacteria, of dysbiotic bacteria. She had very, very low commensal and beneficial flora. There was no parasites and no yeast found in the stool, but her organic acids indicated that she probably had at least one yeast somewhere else in her body, very likely to be in the upper GI tract. And remember that she was also having recurrent yeast infections in her mouth. So the hydrogen sulfide test, it's a urine test, and it's not a test where they send the practitioner a report. A kit is sent to the patient does a urine sample, puts a dipstick in it, and the dipstick is supposed to turn purple within 3 minutes. So Zoe's mum sent me an email and said as soon as she put that dipstick in that urine sample, it went black. Immediately, it stayed black the entire 3 minutes. This was obviously a very strong positive for hydrogen sulfide. The results of the breath test showed very, very elevated hydrogen. And when I looked at this test initially, for me, it looks like she's got a significant amount of fermentation halfway through, going towards the end of her small intestine, peaking up around 120 minutes, which is around the ileocecal valve, which is where the colon and the small intestine meet. Now, this is a very normal result that I would expect to see in somebody that has SIBO. In hindsight, when I look at this now, because of Zoe's incredibly delayed transit time, I think what we're actually looking at is fermentation that starts right at the beginning of the upper GI tract. I don't really think that what we're looking at here is, the end and around the ileocecal valve. I think this is pretty much starting up at the duodenum. But at that time, it was enough for me to understand that she had a significant amount of fermentation and a lot of hydrogen. So again, this is significant. It's significant obviously because it's telling me what's going on in the gut. But it's also significant for me because it's helping me to understand what's going on for Zoe in her brain and how her gut is actually impacting on her neurological inflammation and her mitochondrial function or dysfunction. So coming back to this autointoxication that Ben was talking about this morning, dysbiosis and IBS is very much associated with gut inflammation. But gut inflammation is really pivotal in promoting this endotoxemia, where you've got these, protein fragments that are released from the gut into the systemic circulation and into that cross the blood-brain barrier into the brain, contributing significantly not just to systemic inflammation but also to neuroinflammation. And that neuroinflammation, those lipopolysaccharides, those pro-inflammatory cytokines, have a very significant negative effect on brain function, and as well as the gut-brain connection, and are associated with a significant, a growing and significant number of neurodegenerative diseases, including things like dementia. So Zoe's only 16 years old. She's not thinking about her brain when she's 80. But she already has such a significant amount of neurodegeneration that this is only going to get worse if we're not actually able to do something about it starting now. And outside of Zoe, again, this is something that if a patient of yours has this going on for a period of time, years or even decades, it may actually be the environment in the gut that is leading to that kind of neurodegeneration that you see when they're in their early 50s, early 60s, or in your own parents, in your home, or in yourself if you're anything like me and worry about neurodegeneration when you can't find your keys. So why was I worried about hydrogen sulfide? So hydrogen sulfide is it's actually something that's found in the body. It's a product of some relatively normal biological processes, and in low levels, in normal amounts, it's not problematic. And in fact, in some cases, like hypoxia, it can actually promote mitochondrial health. However, in elevated amounts, such as found in Zoe, hydrogen sulfide actually interferes with mitochondrial function specifically and with energy production. In fact, hydrogen sulfide is thought to be something like 10 times more toxic to the mitochondria than cyanide, given enough quantity. So for Zoe specifically, this was something that was important to me to understand, and was, I thought, extremely clinically significant, because here we have something specific to the gut that is directly having a negative impact on her mitochondria and therefore her brain function. So organic and amino acids, you can actually see here, the big thing is that Zoe's ability to get carbohydrates into the mitochondria in the first place and to get fat into the mitochondria to make energy is significantly impaired. She's not able to do either of those things. And your mitochondria need either glucose or fat to make ATP. Once she's getting it into the mitochondria, it's actually not that difficult for her to make energy out of it, but she's not getting it in there in the first place. So very clearly we've got mitochondrial dysfunction here, and a little bit of oxidative stress as well. So you've probably all heard about the 5R program for treating the gut. So I take that a lot further, and I use the 5R thought process to treat every single patient that I have, whether or not they present with gut symptoms. So the first thing that I think about is what exists in this person's body or in this person's life that needs to be removed, that is preventing them from being healthy. So for Zoe specifically, we're looking to remove inflammatory triggers, we're looking to remove infectious agents, and we're looking to remove oxidative stress. So on top of the anti-inflammatory nutrients that I've put her on, we start her on some antimicrobials, because we've got to start clearing out that toxic gut for Zoe. So the second part of the 5R program is replace. And so we're looking to replace anything that's missing from this person's system that is required for healthy function. So specifically at this time for Zoe, we're looking to replace critical digestive enzymes, antioxidant enzymes, and nutrients that support mitochondrial function. So she's already on NAC. We've added in some digestive enzymes with quite a high amount of lipase, multivitamin and multimineral, some more bile support, the anti-inflammatory products that I mentioned support before, and some of those specific nutrients required for mitochondrial support. So after 1 month on this protocol, Zoe has been able to reduce by about half the antiemetic meds that she's taking. She's able to participate in meal times with her family now. She's feeling less overwhelmed by meals. She's actually eating at a more regular speed, and she's experiencing an overall reduction in pain, although she is reporting a slight increase in feeling generally sort of rubbish, which for her meant kind of flu-y, and she was really unable to articulate more specifically what that meant. And I'll come back to why I think that was happening, apart from potentially it being a little bit of a Herxheimer's reaction from clearing out that gut flora. So how do I proceed forward? So the mitochondria and the neurons, they both require fuel in the form of fat, glucose, and oxygen in order to function, right? And these processes require micronutrients to work. However, being able to tolerate the foods that these nutrients come in and absorb them from the gut is really important. So this is part of the reason that in Zoe's case specifically, in order to support her brain, in order to support her mitochondria, we had to start working with the gut first. Now, as a nutritionist, usually I'm working with the gut first anyway, but in this case, really, there wasn't any other way that I could see forwards aside from treating her brain through her gut. So her dietary strategy, and this is what I discussed with the family, here is the way that we are going to, this is the, gosh, I'm going to blame the baby for this moment. Here is the importance, what's the word? Priority, thank you. Here is a prioritization of how we're going to think about the foods that we're going to be implementing going forward. First and foremost, the first thing that you think about when you're deciding if you're going to eat a food or not is its ability to ferment in the gut. So we are thinking about foods that are low in FODMAP or potentially low on the specific carbohydrate diet. After you've thought about is it going to ferment, yes or no, then we need to think about energy density. Right? I want to be introducing fats and I want to be introducing calories because we need energy for this girl to function. And fats are my preferred form of energy for her because she's got mitochondrial dysfunction, and mitochondria make a lot more energy from fat. You make 109 ATP from a single molecule of fat. You only make 36 from a single molecule of glucose. And also she's extremely underweight and has been continuing to lose weight, and this is of concern to her. I also am talking about calories with this family, which I never do. I never really think about calories that much because calories are a measure of energy, and energy is really critical for this girl. Then third on the list, we're looking at micronutrients and specifically phytonutrients because we need to be providing all of those things that the brain and the mitochondria need to function, and to be providing a lot of antioxidant and anti-inflammatory nutrients. And lastly, fibre, which is a little bit hard to provide on FODMAPs and specific carb because we are talking about what the gut needs to be healthy and because she's got motility and constipation issues. So we talk about all of the different foods. We're combining a couple of different food plans, but this is the thinking that that we've implemented. As it turns out, some of these things worked a lot better than others. The FODMAP diet was a little bit like a miracle. Her mother still talks about the fact that when she started that FODMAP diet was the first time that she saw her daughter really improve, and it was the first time that she had hope. Fats were a disaster. But I'll talk to you about that a little bit more as we go through. So some of the lifestyle interventions that I did included diaphragm breathing. We wanted to actually increase the amount of oxygen that Zoe was taking in. Increasing vagus nerve stimulation via increased gargling, which was Zoe's preferred vagus nerve exercise. She didn't love the gagging, surprise, surprise, and also wasn't very good at it. I ask people to gag until they get a tear because the part of the brain that produces a tear sits next to where you're stimulating the vagus nerve by gagging. So once you've stimulated that vagus nerve enough, it actually stimulates that part of the brain that sits next to it, and you should produce a tear. And Zoe was unable to do that, so she had to make herself gag for so long that she couldn't cope with it anymore and still wasn't getting a tear. So she sort of abandoned that by herself. I asked her to do a bit of ileocecal valve massage, some general abdominal massage, and we started doing oil pulling with a colloidal silver spray to try to address the dysbiosis that was going on in her mouth. But she wasn't loving the fat. Even having it in her mouth was making her feel nauseated, so she wasn't particularly compliant with that intervention either. So by January, this is an email from Zoe's mum. By January, the pain is improving dramatically. Instead of twice a day, it's going down to once every 4 or 5 days. I'm talking about that spike in pain that she was experiencing in her GI. And her overall level of pain is now, most of the time, a 2 or a 3 instead of being a 5 or a 6. And when it's spiking up, it's now just spiking up to a 7. It's not going up to an 11 or 12. She's sleeping much better. Her energy levels have improved, and she's able to do a lot more during the day, including 8 minutes of walking on top of showering and playing the flute, which she wouldn't have been able to do 3 months ago. You can see I've got her on some green tea, and we've talked about the catechins, and Ben talked this morning about the brain benefits of green tea. And I found this very funny, that Zoe's mum specifically remarked that Zoe has now been cleaning out her room by herself, which again for a 16-year-old girl was enough for the mum to remark on that, and didn't require her mum's help with that anymore. She was doing much more flute practice, her bowels are moving more easily, she's only needing to use the magnesium once or twice a week to initiate bowel movement. She's able to go most of the time on her own. She's still getting this hot flash sort of a thing, but it tends to be associated with her spikes of pain. So they're now down to really just once or twice a week instead of twice per day. She comes off the amitriptyline at this time. She's still using the antiemetic meds, but is on a much lower dose. She started taking melatonin, which was prescribed by her physician, and I was very much in favour of that for a couple of reasons. Number one, melatonin is very good for reducing cortisol, and when you have somebody as inflamed and ill as Zoe, stress hormones and cortisol are a big issue. But also melatonin is a brain antioxidant, right? So taking melatonin is going to be reducing the amount of neurological oxidative stress that she has, and it is helping her to sleep a little bit better. Her nausea had reduced significantly, but it's now starting to increase again. So we further look at supporting her bile, and we introduce a juice with carrot, which we know she tolerates, and ginger. And I've asked her to try having some beet and to take it very, very slowly. So she starts with just a teaspoonful of beet in her juice per day, and she increases that as she tolerates it. And actually for Zoe, that was fantastic. She really associated having this beet and having this beet juice with feeling a lot less nausea and actually generally feeling better. So she's starting to really appreciate the relationship between the foods that she's putting into her body and how she's feeling, and to be able to dictate food choices accordingly, which is very good. Now, we hit another bump in the road, February. So in February, Zoe's paediatrician has several months back, before we started working together, given her a referral to this pain management clinic. So first she was at the chronic fatigue clinic, but when she had in Bath, when she had the relapse, she had been considered to be kind of cured of the chronic fatigue syndrome. And so now, because one of her major presenting symptoms was this intense pain, they've referred her off to this pain management clinic. And I discussed it. Zoe and her mother, despite the fact that her pain had reduced very significantly by this time, they felt that they wanted to still go because they wanted to have the physicians and the NHS support that they were getting on side. They wanted to participate and to have a good relationship with that, which I totally appreciated and completely agreed with. And I thought that they would probably come up with some helpful strategies to help her manage pain, breathing exercises. I'm not familiar with their program at all, but thought that there would probably be something useful that came out of that. However, the pain management clinic and the energy management clinic, they're two programs completely disassociated from each other. So the pain management clinic doesn't take into account any of the energy management stuff that is really important for Zoe, because at this stage now, she's not so much considered to be a chronic fatigue issue, now she's considered to be a chronic pain issue, and the medical community that was helping her had separated those things out. So the pain management sort of point of view is to try to help her have some strategies for managing pain, but the exertion of her being at that clinic in the first place is actually causing her to have more pain. So she's gone from having pain every 4 to 5 days now to being once a day again. And when she's in pain, they don't actually have any solution, they don't have any strategy for her except do what you would normally do at home. That being said, from a fatigue perspective, Zoe copes with the increased level of exertion much better than either her or her mother was expecting. And at this time, they have been experimenting with increasing vegetables, trying new varieties of vegetables that they had never tried before. And Zoe very proudly tells me that she's, on one day, actually had 13 different kinds of vegetable, which was fantastic, because she'd gone from basically just having broccoli and carrots for her evening meal. So I was really very proud of her for that. So the pain management clinic really strongly advocated her starting to go back to school full-time and to increase her activity levels. Their general advice, the general strategy was actually just work out what the upper level of pain you can tolerate is and keep it there. And just live at that level of pain. And Zoe, bless her, attempts to comply with that. and has a massive, massive crash. You know, her neurons, her mitochondria, they absolutely couldn't cope with that kind of level of exertion. Remember that pain for her is a feature of her mitochondrial dysfunction. And her membranes in her brain, her membranes in her mitochondria were just still really overstimulated, too close to threshold, and she has this massive crash. She's now vomiting every day, she's in a lot of pain, the hot flashes come back, she's unable to walk, she's struggling to eat, and you know, she's back in crisis. So, Zoe's mum has worked pretty hard at this stage, and she's identified, Zoe's mum, by the way, is a trooper. You know, this is a woman who has gone from cutting a slice of bread and slapping some salami on it to investigating new vegetables, chopping 13 different kinds of vegetables, spending a couple of hours in the kitchen every day preparing meals for her child. You know, she's really impressed me beyond a lot of things with her determination to get her daughter well. So she's worked out 14 foods to which Zoe definitely does not have a negative reaction. And at this stage, we together pull her back basically to that 14 foods and we start again. So that's March. We start again with the anti-inflammatory supplements, we bring her down to those 14 foods. And by May, Zoe has actually recovered from her crash. She's back to where she was before. And she's looking remarkably well compared to her initial presentation. She's actually pretty functional. She's playing the flute, she's participating in her family life, but she's stuck there. We've hit a plateau. We're not really moving forwards. She's still in some pain, it's manageable, but it's still there. She's still battling nausea a little bit. She's still not tolerating a lot of foods. We haven't been able to reintroduce a lot of things. We haven't been able to introduce probiotics at any point because she has a big negative reaction to them. And so her eating is still quite restricted. She's dependent on the supplements, which are propping her up and helping her to function, but you know, they're not really fixing the problem at this point, and we're not really making any progress forwards. So we do some follow-up labs, not all of them again, but just run some of them through. And you can see that now she's actually able to transport glucose and able to transport fat into the mitochondria much more efficiently. But her mitochondrial function itself is actually not fantastic. It's not terrible. But it's not optimal. And she still has a couple of very elevated levels of potentially problematic bacteria, but most of her microbial analysis really shows that everything else is low. She has sort of deficiency dysbiosis at this stage, but she's also not tolerating foods she's not tolerating fermented foods, she's not tolerating probiotics, and she's not tolerating fibre. So the ability to build up beneficial bacteria in her gut is really compromised, and there's a lot of symptoms still of fermentation and dysregulation in the upper GI tract. And you can't feed bacteria in isolation. So if we try to build up the good bacteria, my feeling is that we're just going to end up building up this unhealthy population of bacteria at this point, and she's just still got really a lot of GI dysfunction. So Ben was talking this morning about vitamin C, and there was an image there. I introduced a therapy that I got from Liz Lipsky and Russ Jaff of essentially using high-dose ascorbic acid to provoke an osmotic laxative effect on the bowel. And Ben was talking this morning about the fact that they were doing bowel purges in cases of auto-intoxication, and it's actually something that from the literature, and I've implemented in my clinic in cases where we are stuck or the person is chronically sick, or for when antimicrobials aren't really working effectively. So I discuss it with Zoe, we decide to give it a try. She ends up doing about 20, including 14 consecutive days. And from the second or the third one, it's very obvious to Zoe and her mother that these are doing something good for her, even though they're horrible to do. And because they were immediately, obviously helping her, her energy levels picked up, her eyes were brighter, she had more energy, her gut felt much better, her pain reduced. They were very committed to keeping going and keeping that on as a therapy. So Zoe has been also actually able to use vitamin C and ascorbic acid as a pick-me-up now when she has a hiccup of any kind, when she eats a food that causes her a reaction, when she's trying to introduce something, when she's overexerted, she can actually come back to the ascorbic acid and get herself over that hump and back into a good place. So after that 20, and 20 is a massive amount, I would like to say, I normally when I'm doing this with patients, it's 1 a week, sometimes once a month. She did 14 days in a row. And this intervention removed what she described as an entire layer of pain. There's a vast improvement in her nausea. She's able to completely come off the antiemetic meds as a result of that. Her energy levels improve and take a massive step forwards. And her overall stamina and recovery from exertion is really noticeably improved. So remember, Ben this morning said that the brain actually has the biggest reserve of vitamin C in the body. And vitamin C has actually been shown to increase tetrahydrobiopterin, which is part of the methylation cycle and very critical for neurotransmitters and hormones, but also very, very critical for nitric oxide synthase and reducing neurological inflammation. So vitamin C increases endothelial nitric oxide synthase, which increases vascular blood flow. It provides improved neuronal function, so those neurons are working a lot better and therefore better neurotransmission and much better vascular cognition. It's really, really good for the brain. It is also obviously a fantastic antioxidant, and when it comes to mitochondria specifically, the mitochondria can recycle ascorbates. So this in turn has a very positive impact because it helps to reduce oxidative stress in the mitochondria itself. So as well as having a really big positive impact on Zoe's gut and her gut function, it's also had this knock-on effect on her mitochondria and on her brain. And here is a really critical thing. In the process of her going through this osmotic laxative effect, we discovered that Zoe's gastric emptying and transit time are severely, severely delayed. She's got up to 5 hours gastric emptying, and it's often 3 hours. But if she does her vagus nerve exercises, which she hasn't really been that good about doing, it comes out now, then the transit time reduces by 2 hours from her doing a 5-minute gargle before she does the vitamin C. So what does that tell us? All right, remember one of my initial thought processes was the vagus nerve. That one of the things that jumped out at me from the very beginning of this case was the vagus nerve, and then it kind of got a little bit lost. The importance of the vagus nerve was always there, but it got a bit lost in the process of what we were doing. So it becomes abundantly obvious that the vagus nerve is right at the heart of Zoe's issues. And the vagus nerve is the gut-brain information superhighway. It's not a single nerve. It is actually a massive nerve complex, and it is involved in parasympathetic control of most of the organs in the body, coming from the brain stem. It's also known as the 10th cranial nerve, and it is responsible, amongst many other things, for peristalsis and for muscle movement in the mouth, including the gag reflex, and for sweating, which, remember, has been an issue for Zoe. So one of the ways that you can actually differentiate a brain-based gut digestive disorder in your clinic as opposed to a gut-based gut disorder is there a motility issue? Because motility is brain-based. Right? Your brain fires from your brain stem into the vagus nerve. The vagus nerve then fires into your enteric nervous system, which activates something known as your migrating motor complex. Your migrating motor complex is responsible for motility and movement through the GI tract. If you've lost motility, you don't move your food. If you don't move your food, it ferments. You end up with microbial overgrowth. And you're also not releasing digestive enzymes or hydrochloric acid. Your migrating motor complex is basically a group of motor neurons, but it's like a broom that is sweeping through your small intestine and your intestine in between interdigestive muscle contractions. So it is actually really critically important for making sure that you are cleaning out your upper part of your GI tract appropriately. Bile secretion is part of phase 2 of the migrating motor complex, and it's very likely to be part of the reason that Zoe is not tolerating fats, is because she basically doesn't really have any motility. Her migrating motor complex isn't firing, and therefore she's not making bile. Even though we're supporting her with bile supplements, it's not actually helping her to regain gut function. And because she has a brain-gut axis disorder that is causing her gut function, we're not going to fix this with gut supplements. So while we're actually actively treating her brain through her gut, we also have to treat her gut by treating her brain. It's part of Zoe's paradox. So the vagus nerve is its parasympathetic nerve. It requires acetylcholine for neurotransmission. So we've talked about the role of acetylcholine in reducing microglial inflammation and neurological inflammation, but particularly for the parasympathetic system, it's really important. And Zoe was taking amentriptyline for a long time, and amitriptyline inhibits the release of acetylcholine from parasympathetic nerve terminals. So it's another med that she was taking in order to help her to reduce her symptoms that have actually actively prevented her from being able to heal and regenerate. So some of the strategies for rehabilitating the vagus nerve include gargling, gaggling, and singing, things that actually activate that part of the brain. Coffee enemas, which I have not been able to bring myself to suggest to this family. I've used them effectively with other people, but I just feel like it would be a step too far for this mother specifically. So the gargling, gaggling, and singing, these are active kinetic therapies, and we're also going to introduce some passive kinetic therapies that help to stimulate the vagus nerve, and acetylcholine support, obviously. So with a passive therapy, you're basically the recipient. You're hopefully relaxed, lying there and having something done to you, but it's a kinetic therapy, so it involves movement of some kind. So specific to the vagus nerve, some of the therapies that you might think about are craniosacral therapy and cranial osteopathy. So at that point, we actually go for cranial osteopathy with Zoe. And I've listed some of the other passive kinetic therapies that you can consider that really help to stimulate different regions of the brain and different functions of the brain. And some of the nutritional compounds that you can use to help to support acetylcholine specifically include L-acetylcarnitine, pantothenic acid, and glycerophosphcholine. But in somebody who is very fragile or very fatigued, even if they desperately need acetylcholine, it may trigger a crash because the stimulation will be too much for the neurons. If the neurons are too close to thresholds, then creating that stimulation, even when it is really needed, will actually just be too much. So I wouldn't have been able to do this for Zoe up until she was very, very much improved, because she just didn't have the neuronal capacity or the mitochondrial capacity for acetylcholine stimulation. So the other thing about stimulating the vagus nerve and acetylcholine specifically is that you might experience some cramping, some nausea, and increased GI motility because you're starting now to stimulate that that nerve, which is now stimulating the gut. So again, with Zoe, I wouldn't really have been able to do it until her gut was so much improved, because nausea and cramping were things that she was actively struggling with and wouldn't really have tolerated particularly well an increase in those things. Lastly, foods that support acetylcholine are fats, which Zoe doesn't tolerate, very specifically choline, and there are a lot of foods that are known to be high in choline. But again, Zoe's not actually eating any of these things because she's not tolerating fats at all. She's actively avoiding all fats, including even just a little bit of olive oil for cooking or in salad dressing. She can't tolerate any. So, eating for brain energy, eating to support mitochondria, essentially what we're thinking about is addressing deficiencies, providing protection in the form of antioxidants and making mitochondria more efficient. So this helps to provide the proper amount of fuel, which helps mitochondria to function best, and is directly related, therefore, to metabolic energy. And the overall structure of eating for your mitochondria includes protective antioxidants, anti-inflammatory nutrients. Ben really covered this pretty well this morning. The intricacies of why we're considering these, dietary and therapeutic strategies for supporting mitochondrial function and brain health. Low grain, gluten-free, therapeutic foods for energy, which I'll run through very quickly, ketogenic style diet and using ketones for fuel for the brain, and potentially some intermittent fasting or some caloric restriction. So particularly, I like to really focus on high quality dietary fats because a healthy brain really thrives on fats, and because the mitochondria use fat for fuel in a significantly more efficient way than they're able to use glucose. Plus, in somebody whose mitochondria are really struggling and degenerated, it's a cleaner burning source of fuel for the mitochondria. It doesn't create as much pro-oxidative chemicals as just the process of creating ATP in the first place. I'm not really going to go into detail on the specifics, but I've included them here and why these specific foods are very, very good for the brain and for the mitochondria. So I'll leave you to read through these yourself at home. Again, you'll be familiar with them. These are things that we call superfoods. And we all are really familiar with why these foods are better for us than white bread sandwich. But think about the fact that in Zoe's specific case, she almost couldn't eat any of these foods because they're either fat or they're high in FODMAP. So in somebody that has specifically got GI dysfunction and they're not tolerating fats because they're not making bile because their vagus nerve isn't working, or they've got a significant amount of dysbiosis and they're fermenting foods in the upper GI tract, you can't have them on broccoli and coconut oil, unfortunately. So rehabilitating the gut really had to come first so that we could, in fact, introduce foods to rehabilitate the mitochondria. So now we're in June. We've gone through this process of the vitamin C purge, and we are now able to start introducing fermented foods and broadening Zoe's diet out slowly, but this time successfully. And we're now able to introduce probiotics, although I waited about a month after introducing fermented foods until I started her on probiotics, but because I was apprehensive about doing that, but actually she tolerated them like a champion. So clearly now we've got the gut in a place where we're able to start really introducing therapeutic foods and broadening out the process, which was exciting. It had taken a long time. She's no longer losing weight at this point. Her weight has stabilised, but she was losing weight for a long time, and it was very concerning to her, her mother and her paediatrician. We stabilised her weight using a high-calorie smoothie, which probably tasted terrible because she couldn't tolerate 95 things, but it was... Can I take the question at the end? Is that all right? Yeah. And now it's time to repopulate the gut. I'm also excited because I'm like, yes, the gut's rehabilitated. Now we can start doing some really interesting stuff with the brain, with the mitochondria, with the vagus nerve. Exciting times. So re-inoculation is obviously critical. And so now we come to August, and I'm ready. I'm ready to get in there and start doing some cool things with the mitochondria. I'm ready to start doing some neurological interventions. And it comes absolutely to the threshold at this point that Zoe is unable to tolerate and digest fats. Her ability to process fats is almost zero. And any kind of fat whatsoever has a very, very strong reaction, which is nausea and pain. So there goes all my big plans for mitochondrial rehabilitation, ketogenic style eating plan. She can't tolerate supplemental fats. In fact, the EFAs that I gave her for that first month obviously helped her. I don't know how many of them she was absorbing at the end of the day after all of that because her bile is so... but it was also probably potentiating the pain and the digestive discomfort that she was experiencing, but we couldn't separate it out. It was very unclear what was causing what at that very early stage. but she wasn't able to tolerate, even as we moved forwards with her program, it was very clear that she couldn't tolerate even small amounts of fish oil, even in capsules. So that hasn't been something that has come through her entire program. And so she's not tolerating any dietary fats, she's not tolerating any supplemental fats whatsoever. And so we now go through this process of the next intervention for Zoe is actually improving fat tolerance. And fat digestion and absorption. So we put her on targeted foods specifically, and again I got this, yet another look from her mother. When I said artichoke, I really thought that was going to be the thing that pushed this poor mother over the edge, until I told her that you can get artichoke in a jar, and she was like, oh, okay, we can do this. This woman she's making kombucha, she's fermenting lettuce on her bench top. Artichoke was the thing that might have pushed her over the edge. I introduced some nutritional compounds to support bile production and fat absorption. And actually 1 month into this program, Zoe's doing very well. She is not only tolerating all of these foods, but she's enjoying them. She's starting to be able to reintroduce fats into her diet much more successfully now. And I continue to be impressed by the determination of this family to adopt my suggestion of things that they never even dreamed existed. So I'm working my way up to those coffee enemas. They're roasting and grinding dandelion coffee, they've tackled kombucha SCOBY, they've really done it, and all credit to them, because Zoe is now much better, right? So she's able to navigate her doctor's and her dietitian's appointments with confidence, because she has a very comprehensive understanding about which foods promote wellness for her and which ones make her feel less good. She had an appointment recently where she was told she wasn't eating anywhere near enough carbohydrates and she needed to introduce grains, and she was able to really have that conversation in a very calm, very rational way and negotiate her way out of it. And continue forwards. She's still using her inhalers, but she's off all other medications completely. She's just started back at school full-time, and she is about to be taking her A-levels. And she's excited and she's confident about her ability to do this, instead of scared about her future and what that future brings. She's participating in life. She goes on vacation. She can go to the beach. She's able to socialise and have a life outside of the house. At the end of June, she travelled to Germany and spent 5 days travelling around Germany with music school, playing the flute, which was a very, very big deal for her. This trip had a little bit of an impact, but she recovered within a couple of days. She recovers from overexertion well and quickly, and the visual change in this girl is remarkable. She really went from being somebody that looked sick, that after 12 minutes was physically deteriorating in front of my eyes, to being abundantly healthy. She's glowing, she's got a fantastic, healthy look to her. And we've essentially done that with food. And some targeted nutritional supplements and therapies. So what have we really done? We've treated the brain and we've treated the mitochondria via the guts. We've reduced oxidative stress and we've reduced free radical load. We've reduced systemic and neurological inflammation. We've increased mitochondrial function, and we've used both active and passive kinetic therapies to stimulate that vagus nerve and improve her gut-brain connection. There's still work to do. We've still got things that we need to do. We're certainly not at the end of the road. There's definitely mitochondrial support and rehabilitation that we need to work on. We still have some vagus nerve to do for sure. And we've got some neurological repair work to do. We have yet to actually work specifically on the part of her brain that was damaged in that traumatic brain injury. But we're 10 months into Zoe's program, and by assessing mitochondrial function as it pertains to brain health and understanding the connection between the gut and the brain and the gut, we've really been able to move her forwards very, very effectively. So I'm going to leave you with a couple of things. 3 of the more common outcomes of brain degeneration include fatigue and gastrointestinal problems. So when you see somebody presenting in your clinic with GI problems, you have to think brain, at least as part of that differential diagnosis. And when you see somebody presenting in your clinic with fatigue, you also have to think brain. Depression seems a little bit more obvious, the brain is involved. And a word from Zoe. Zoe really wanted, when I asked her if I could present her case, she said yes, but she wanted to add a couple of things. Number one, that with an undiagnosed illness, that you mustn't believe that you are not sick, even if you're being told there's nothing wrong with you, and that you can't get better, even if they don't know what it is. Number two, Zoe specifically noticed that vegetables were the key food for her. That when she ate more vegetables, she had more energy and feels better generally. And she noticed that when she was in Germany, where her supply of vegetables was restricted because she was eating out of hotel rooms. And that the food that makes her feel better definitely tastes better to her. And this came from the intervention where I introduced radishes and beet greens and artichoke. Because she really enjoyed them because they made her feel good. So that's what Zoe had to say about her case. So I'm talking into your break now. So any questions quickly? Or do I need to just wrap it up? Okay, all right. So then that brings me to the end of my presentation. I think you've got about 10 minutes to grab a quick cup of tea and to go to the bathroom.
Say that's one of the best and most eloquent dissections of a case I've ever seen. I don't know about you, so if we can just give Robin another round of applause. It's amazing. So thank you, and we'll be back at about 20 past if we can.